Hello, welcome back. I'm Alison Piri. We are going to continue with colorectal cancer, but this time we are going to look at the colostomy. So, colostomy normally comes as a complication of colon cancer after surgery has been done. So, the stoma is the definition of term saying the stoma is the opening of the surface of the abdomen created when the intestine is bled through the abdominal wall and sutured to the skin. It may be permanent or temporary. Fecal matter is diverted through the stoma to the outside of the abdominal wall. So that's the essence of creating this colostomy, is to divert the fecal matter from the intestines. Instead of them coming through the rectum, the anus, they have to come through the artificial anus that has been created through the abdominal wall. Definition of terms. One of the definition of terms is ostomy. An ostomy is a surgical procedure in which an opening is made to allow the passage of intestinal contents from the bowel to outside. From the bowel to outside. We also have an ileostomy, is an opening from the ileum through the abdominal wall. So if you look at the anatomy and physiology of the abdomen, especially the bowels, we have the ileum, the rectum. So if we are making an opening in the region of the ileum, that opening becomes ileostomy. It's an opening from the ileum through the abdominal wall. Then we also have a cestostomy, is an opening between the cecum and the abdominal wall. So any opening that is made between the cecum and the abdominal wall is called the cestostomy. We also have a colostomy, which is our discussion coming as a complication after surgery. We're saying is an opening between the colon and the abdominal wall. So an opening that can be made between the colon and abdominal wall is called a colostomy. So in colostomy, the proximal end of the colon is sutured to the skin. The proximal end of the colon is sutured to the skin. So there is proximal and the distal. The proximal is the part that is the first part of the colon after surgery, and the distal part is the last end of the colony where the resection has been done. So we're saying the proximal end, the first part of it, is sutured to the skin. There is a diagram here which is showing sites for colostomy. A diagram which is showing some sites for colostomy. We have the transverse. Area. We are saying transverse colostomy can be done there. We also have ascending colostomy. It can be done there. We also have the descending or sigmoid colostomy. It can also be done there. So all these, if you look at them, they are getting their names from the anatomy of these organs. So let us look at the indications for colostomy. We have cancer of the bowel. Why is colostomy indicated in cancer of bowel? In cancer of bowel, colostomy is indicated so that after the resection of the affected bowel, the bowel can be given chance to heal before anastomosis can be done, before anastomosis can be done. So in most cases, this can be permanent or temporal. We also have diverticulitis. This is a chronic inflammatory condition of the diverticulum. It is also one of the indications of colostomy. Then there's also imperforate anus in situations where someone is just born with the anus that is too small, anus that is too small. So during surgical intervention, when this anus which is too small is being directed for it to heal, you may want to divert the uh, the emptying of fecal matter through the colostomy so that this area heals enough. There's also Hirschsprung disease. In Hirschsprung disease, we know that this is a uh, congenital disease which presents with constipations in the large or small bowels, and in most cases, it affects the ascending and descending colon. It affects the ascending and the descending colon. So when there's so much constipation in the large bowel, hard stool, hard stool can perforate the bowels, and when bowels have been perforated, we really need to give them chance to heal, and we can create a stoma by so doing, which can be permanent or temporal. Then trauma to the bowel. Trauma to the bowel. Any trauma that to the bowel which is so severe, so extensive, we may want to create a stoma so that so that as the bowel which have been repaired undergoes healing, someone can be answering the call of nature through the artificial anus which has been created on the abdominal wall. Another indication for colostomy, it is in the severe Singhorn's disease. Severe Singhorn's disease. So those were the indications for colostomy. So let us look at the pre-op care of someone who is about to undergo colostomy. Let us look at pre-op care that is to be given someone who is to undergo colostomy. So preoperative care focuses on patient teaching and psychological care. Preoperative care focuses on patient teaching and psychological care. We all know that answering the call of nature is done through the normal way, where someone has to open bowels through the anus. And in a situation where someone is anticipated in having colostomy, you just imagine someone opening bowels, defecating through an artificial anus that is being made on the abdominal wall. It becomes an embarrassment, and it doesn't just feel good. So patient who is about to undergo colostomy, we need to counsel them about the nature of the operation that they're about to go. So the nurse assesses the patient's knowledge and understanding of the proposed surgery and its outcomes. Just like I've said, you talk to the patient. In talking to the patient, you try to assess the knowledge of the patient as to regards the surgery which is about to undergo. This includes brief view of GIT tract structure and functioning and the nature of functioning of the stomach. So in trying to discuss further with the patient, in trying to help them understand why they have to go for colostomy, we help them to understand how the GIT works. What is the function of the area where the stoma has to be made, so that even when the patient goes for surgery, they have a good understanding of the operation. Psychological care, we are saying emotional preparation for ostomy surgery is extremely important. Surgery is extremely important. We emphasize the need for the patient to undergo an operation. The nurse Also encourages the patient to verbalize feelings related to the radical change to body image and the function. Like I've said, someone is naturally that they have to open their bowels through the rectum, but in this case, when colostomy has been done, their um, opening of bowels will be diverted. So in this way, the patient may feel uncomfortable. So we need to prepare them psychologically, and we need uh, to let them know that it could be permanent or it could be temporal, depending on the findings that will be there in theater. Validating the appropriateness of these concerns lays in the family for effective working relationship with the patient. So many of the times that when we are explaining some of the when we're explaining the importance of this surgery to patient, we also need to involve the family members. The family members they have to be involved so that they know what is going on on their beloved ones. The patient may need to progress through the grieving process, and if the patient is in the shock state, specific factual teachings may be effective. So we are saying it's not every patient who may accept to undergo um, may accept to undergo an operation of such kind. Others they may receive it with some depression. So you need to further explain, if possible. Also involve some people who have undergone such procedure before, so that they can also offer psychological care. The nurse offers acceptance of all feelings and reinforces the importance of open communication. So this point is also trying to say that we really don't need to block patients, but we need to give them an opportunity, chance to explain their feelings about the operation, so that we can further help them with the information in which they still understand. The patient should know that to accept the patient should know what to expect in the postoperative period. This simply means that when information has been given to the patient as regards to an operation, the patient is equipped with knowledge and what is expected of him or her when surgery has been done. The nurse discusses the management of postoperative pain. We know that surgery is associated with pain, so we need to control pain when the patient has come from theater. And in most cases, patients they tend to fear so much of pain after an operation. So we need to explain to them that some strong analgesics are there to help such severe pain which they may have after an operation. And the purpose of nasogastric tube and IV lines. IV lines and nasogastric tubes, they need to be explained to the patient. Like the insertion of nasogastric tube, many are the times that patients who have gone to theater without nasogastric tube, and in most cases of operations involving the abdomen, they have died from aspiration after surgery. So we need to explain to patients that the NG tube actually helps to prevent aspiration after surgery, and IV lines are there for administering of IV fluids as one way of feeding the patient, as they are new orally when going to theater, and after theater they'll also be new orally. So for nutrition purposes, we'll be giving some fluids through the IV lines to the patient. Bowel cleaning is also performed and may include the use of enemas, laxatives, and antibiotics to reduce intestinal bacteria flora. Before the patient goes to theater, it is important that enema is is prepared and given to the patient. At times, the patient may be constipated with the help of enema and the laxatives. This may help to get rid of hard stool which has been there, and also to reduce of bacteria flora. These are bacteria which are found in the intestine, like the Escherichia coli, which are the pneumophora of the intestinal contents. So these they help to reduce the bacterial flora. Postoperative teaching: when patient has come back from theater, nursing care should focus on assessing the stomach. So like I said in the beginning that this is coming as a complication of cancer of colon. So our major intervention is on the stomach. Much of our interventions that we have to do when someone has undergone colostomy is on the stomach. So the stomach is assessed for drainage. How active is the stomach? What is coming out from the stomach? If it's fecal matter, is it hard or is it loose? That has to be documented. If uh, is it bleeding in the edges? The stomach is sutured to the abdominal wall. Are the sutures intact, or the sutures they've come out? All those needs to be assessed. And when emptying the stomach, we need to record how much we've emptied and add it to the output. Protecting the skin. Protecting the skin around the stomach, we know that on the stomach what will be coming out is the fecal matter. So to protect the skin from becoming infected, we need to continuously clean the skin around it and put some Vaseline to prevent skin excoriation. Selecting the stomach punch. Selecting the stomach punch. When changing the stomach, we need to look at the size of the wound and make a good size of a punch which can easily fit on the stomach, so that we avoid the seeping of fecal matter onto the skin of the abdomen, which can bring about infection. Assisting the patient to adapt psychologically to change body image. Like I've said in the beginning, that having a colostomy bag, it can be a big challenge, as someone has diverted the mode of answering the call of nature. Instead of using the rectum, they're now using the stomach, which has been made in the abdominal wall. So there is that change of body image. Someone may not freely be mixed with others for the fear that he may be making other people uncomfortable in the environment where he is. So they may start to experience self-isolation in the group of people. So we really need to explain to the patient that this may just be for a short period of time, and later on the colostomy can be taken out, and the normal opening of bowels may resume in the cases where a temporal colostrum has been performed. Then the maintenance of fluid and electrolytes balance. Maintenance of fluids and electrolyte balance. Patient is having a colostomy. We really need to maintain the fluids and electrolyte balance, so that the patient is not exposed to constipation. If the stool which will be coming out from the stomach is constipated, it may also be another source of pain. So the patient is supposed to be given enough fluids to prevent constipation, as well as being given enough IV fluids to balance the electrolytes in the body. Stomach monitoring and managing the wound. The stomach needs to be clean around it, so that no infection should set on it. And the managing the managing of the wound, dressing it with stellar gauze as well as stellar forceps so that there is no infection that can set in post-operatively. Changing the ostomy punch, there are two types of colostomy bags, the stripe type and the stick-on type. Typically, the stick-on type is more common and easier to change. So we're saying there are two types of colostomy bags, the stripe-on type and the stick-on type. So meaning there is another one which adheres to the skin. There is another one which adheres to the skin, and there's another one which, for it to adhere to the skin, you need to reinforce it with a strapping. So I'm saying typically the stick type is more common and easier to change. So it is more comfortable to wear. The one which was saying it is more common and easier to change, was saying it is more comfortable to wear. You may not realize that someone has a colostomy bag because of the manner in which it has been designed. So the following guidelines should be taken in mind while changing the stoma. So you need to take note of the ostomy punch. You need to take note of the ostomy punch. Look at it, and when making the size of the stoma, you need to make it exactly in relation to the size of the stoma that has been created. Also, you also need to look at the site where the colostome has been made, like some of the sites which we've already discussed. And here there is an example of a colostome bag that has been applied. That has been applied on the patient. So this is an example of a colostome bag that has been applied on the stoma, and the pouch has been resected exactly to fit the stoma that has been created on the abdominal wall. So stoma measurement. Use the measuring guide and sample diameters and cut the ostomy apprises to fit the stoma, and should be about 7 to 8 millimeters larger than the stoma. Use the same procedure to prepare the skin barrier. So we're saying you need to make the you need to get the colostrum bag, get the stoma punch, and make it a big larger, about 7 to 8 centimeters larger than the stoma, so that it is able to fit inside the stoma that has been created. If you make it too tight, it also becomes if you make it too tight, it becomes a source of infection, because there'll be heat around it, and it can become a source of infection. So you need to make it a bit bigger so that it is a bit loose around the stoma. Then applying or removing the stoma, center the punch opening over the stoma, then gently place into place and hold for at least 30 seconds to seal. So when you apply, you start at the center of the stoma. After attaching it to the center of the stoma, you start placing it bit by bit, and at least for about 30 seconds, and seal it. You need to start from the center so that some other areas are not left out. Some other areas are not left out. If other areas have been left out, there will be a leakage. There will be leakage, and that's where the fecal matter will be coming out from the skin instead of fecal matter going into the stoma. So it will be a source of leakage if sealing wasn't done well. When a punch seal leaks, the punch should be immediately changed, not tapped. So just like I've said, it is important that when applying the colostrum bag on the stoma, we gently start applying it gently from the center so that we avoid leaking. If the colostrum bag is leaking, it's better we remove it immediately and replace it with a bag that is okay. The skin should be gently but thoroughly rinsed and padded dry. So we also need to remember that for the colostrum bag to adhere nicely to the skin of the abdomen, the skin needs to be dry. The skin needs to be dry. So it has to be cleaned first, and thereafter we need to apply the stoma, and it's going to adhere to the skin of the abdomen. So care of the skin, we say cleanse the skin with warm water and dry thoroughly. Use soap only if stool adheres to the skin. Rinse thoroughly with water. Assess peristoma, skin and the stomach carefully for signs of irritation or infection. I've said in my explanation, I said it is important that when we have attached the colostrum back to the skin, there is no leakage. There is no leakage. The leakage may be a source of infection because fecal matter will be coming out into the abdominal wall where it is going to come into contact with the skin. So to avoid such, it's better we clean the skin thoroughly, dry it, and put the colostrum bag starting from the center so that we avoid leaving other areas unattended to. That's the end of our discussion.